Thank you again, and thank you for being here. So this is kind of a little bit back to the ED, but right upper quadrant pain more than gallstones. So my objectives today is discuss pathological conditions with presenting with acute or subacute right upper quadrant pain. And I'm going to focus on conditions where ultrasound is the recommended first imaging modality. So we'll talk about the gallbladder, the biliary tree, and then show some cases in the liver and other. And it will be a case-based discussion. So, everybody talks about the ACR criteria, and certainly for a patient who has right upper quadrant pain and fever, ultrasound is the first modality you should be doing, and then MR with contrast or CT with contrast, relatively highly graded as well if ultrasound doesn't give the answer. So let us start with a gallbladder, and I will start with this case. So this is a 50-year-old man with right upper quadrant pain, fever, and a high white count. And this is how we see his gallbladder. And he wasn't that tender over the gallbladder. See, he had negative sonographic Murphy sign. So what do we see? So we see a stone within the gallbladder, which is echogenic material. But what is striking is if you see the shape of the gallbladder, it's not normal, right? The gallbladder should be oval. So even if the patient has good cholecystitis, gallbladder is distended, it should be oval in shape. And there is a focal outpouching. And the other thing that is noticed is the wall of the gallbladder, which should normally be echogenic. You don't see that echogenic line here, and you don't really see the echogenic line in the fundus either. So the fact that he has a negative sonographic Murphy sign doesn't dissuade me for the diagnosis. In this patient, I'm highly suspicious that the patient has acute cholecystitis with perforation. If it's perforated, it's likely because there is, gangrenous cholecystitis. The gallbladder is ischemic. So based on this, we recommend a CT because it's complicated acute cholecystitis. And basically, the CT confirms our finding. The gallbladder wall is thickened. There is fat stranding around the fundus of the gallbladder. And then there is this focal perforation of the gallbladder into the liver. And so our diagnosis was acute cholecystitis with focal perforation. The patient was initially treated with IV antibiotics and percutaneous cholecystostomy. And then he had surgery 4 months later, and he had to have laparoscopic cholecystectomy converted into open surgery because of extensive adhesions and inflammation involving the gallbladder neck. So we all know about acute cholecystitis. It's basically the mechanism is obstruction of the cystic duct with a stone, and there is secondary distension of the gallbladder. There's often edema and hemorrhage in the gallbladder wall, and of course the most common cause is stone. And if you have prolonged cystic duct obstruction, you'll have mural inflammation, and in high-risk patients, it can lead to ischemia and gangrenous changes and eventually perforation. And this complicated cholecystitis happen in 2 to 30% of cases, depending on what population you deal with, right? If they're older patients who have cardiac history or diabetic, their risk of having a complication will be much higher. And it's important to diagnose them and recognize that because these patients have increased morbidity and mortality, and they all require really emergent surgical intervention. So when we just talk first about uncomplicated acute cholecystitis, what do you need to see to make a diagnosis? You need to have an impacted stone in the neck of the gallbladder or the cystic duct. You have to have a distended gallbladder because that's a mechanism. The neck is obstructed. The sonographic Murphy sign, which is focal tenderness over the gallbladder, not just tenderness everywhere, but more. And if you do it yourself and you look at the patient will wince. Okay, that's, if it's present, it's helpful. If it's absent, it's not helpful. And then there's some ancillary signs like gallbladder wall thickening, pericholecystic fluid, which is great if they're there, like there are Herniskis, there is gallbladder wall edema, but they're not as specific. And so one of the things to teach the sonographers is that how do you make sure that the stone is impacted? So it's another case, right? The gallbladder is clearly distended. Maybe there's a little bit of gallbladder wall edema, not that much, but we move the patient in multiple positions. We put the patient semi-prone. We put the patient in decubitus, and this gallstone doesn't move. So that's really, really helpful. Now, I think diagnosis gangrenous cholecystitis is very challenging. And so I'm going to spend a little bit of time talking about it because I've noticed that I have missed some cases, and over the practice, other people have missed them too. So it can be, again, depending on your patient population, it can be in up to 40% of patients with acute cholecystitis. And what happened in these cases is this gallbladder wall ischemia, and then you can have necrosis and perforation. And the accurate preoperative diagnosis is not made as often as you would think. So I think what's important is also look at the clinical context. So now if I have a patient with right upper quadrant pain, the first thing I do is look at their lab value. Do they have an elevated white count? This typically patients will have an elevated white count over 10 to 15,000. They may have an abnormal ALT. The typical patient will be a male, obese patient with a cardiovascular history of diabetes. And the management, and this patient can be very, very sick. So they need to have really emergent management. Usually it's cholecystostomy first, especially if they're very sick, and then surgical management. So what are the findings that should make you think about this entity? And this is a patient where we made the diagnosis of acute cholecystitis, but we did not talk about gangrenous cholecystitis. If you notice, that patient also had a negative Murphy sign. But when do we need to think about it? So you want to see if there is loss of the focal echogenic wall, right? At the fundus, you should see, and the fundus is usually where perforation happen more often because it's a less vascularized area of the gallbladder. If you have echogenic fat near the neck of the gallbladder, again, the ultrasound equivalent of fat stranding on CT is echogenic fat. If there are intraluminal membranes or intraluminal debris in addition to the stones, it's a hemorrhage within the gallbladder. If there is a symmetric wall thickening and a striated wall. Okay, so on this patient, we should have prospectively suggested the possibility of gangrenous cholecystitis. Another patient, so distended gallbladder, striated wall with multiple layers, and on CT, or MR, if you give contrast, you're going to do the same thing. You're going to see the wall of the gallbladder, both on CT and MR with contrast should enhance. And here you have interruption of this enhancement because that's an area of ischemia and potentially focal perforation. So this is really, really helpful in these cases. Another example, same thing on ultrasound, right? So this is a patient who has a stone in the neck of the gallbladder, a distended gallbladder, a lot of debris, but you don't even see the echogenic wall, right? And in this particular case near the fundus, it is thickened there, but then there is a defect. So these are all findings that we should really focus on and raise that possibility for our clinicians. So this is a case where it was completely missed. This gallbladder was called normal. That this was a 26-year-old man who had right upper quadrant pain, nausea, and vomiting. And this gallbladder was just called normal. There was no syneclipse. And I think the sonographer didn't really image the neck of the gallbladder, but this is what was said at the time. And the patient was not doing well, had a very, high white count. And the patient ended up having an MR. And on MR, you can see that there is interruption of the enhancement of the gallbladder wall here. In addition, there is also hyperenhancement of the liver parenchyma around the gallbladder, which is a sign of inflammation. So all these findings consistent with gangrenous cholecystitis. Now, some other tricks to image the gallbladder next. So you obviously would decube the patient. You can put them semi-prone. This particular patient also had right upper quadrant pain. The sonographer said, I don't see any stones. I said, okay, well, just make the patient stand. And he was well enough to stand. And long and behold, here we see the neck in the stone in the neck of the gallbladder. So I'm hoping that this sonographer will remember this trick for next time. Now, emphysematous cholecystitis By definition, to make a diagnosis, it's also basically, secondary to ischemia, but you need to have air in the gallbladder wall. And so here and the way I differentiate this from, let's say, a porcelain gallbladder is that you see this dirty shadowing, and perhaps you see it a little bit better on the clip right here. It comes anyway. So this was a diabetic patient, very high white count. And in these patients, you have to have a really high level of suspicion. So here's kind of the dirty shadowing in a non-dependent fashion. And then the patient obviously had a CT scan, which nicely confirms air not just in the lumen, but in the gallbladder wall. And at pathology, again, it was gangrenous cholecystitis, but with air within the gallbladder wall. Now, you can have air in the gallbladder in patient with acute cholecystitis for some other reason. So this is a patient who had also an old patient with worsening abdominal pain. So there's a lot of junk and debris within the gallbladder, stone, maybe some fossa of air, we weren't sure. But if you look at it here, there's a break in the gallbladder wall, and there's an outpouching. And if a patient has air, then you have to suggest the possibility, which was confirmed on the CT scan here, that the gallbladder would fistulize in the adjacent bowel, usually duodenum. And you know that that's one of the mechanisms why you can have a gallstone ileus as well if this patient doesn't present acutely. So acalculous cholecystitis is another cause of right upper quadrant pain. Now, it's less common than calculous cholecystitis. The mechanism is hypomotility and biliary stasis, which leads to functional obstruction and bacterial overgrowth. And what you're going to see is a distended gallbladder. Now, these patients are also at risk for ischemia, particularly because oftentimes it happens in really sick patient, ICU patient, a cancer patient, and these patients also have a risk of gangrene and perforation. And it's a little bit more difficult, I feel, to make the diagnosis, but you have to think about it. And so patients who are anticoagulant can also have hemorrhagic cholecystitis. Again, most of these patients are very sick, so they're going to be treated with cholecystostomy. And so this is a bone marrow transplant with low platelets, which had severe right upper quadrant pain. And you see a very distended gallbladder filled with, echogenic material, blood clot, and what have you. And when they puncture the gallbladder for cholecystectomy, they confirm the diagnosis of hemorrhagic cholecystitis. Now let's talk about some pitfalls now. First of all, a thick wall in and of itself, isolated, does not mean acute cholecystitis. So this is a patient who has a very thick gallbladder wall, but the gallbladder is not distended. On the contrary, it's contracted, and the patient was not particularly tender. And I've seen the very thick gallbladder wall with multi-layer, hypoechoic as well, hyperechoic areas in patient with hepatitis. Patients who have heart failure can also have edema in the gallbladder wall. This is a patient in cardiac ICU with elevated liver function test. So there is this edema, but if you look at the portal vein here, there's a very phasic flow. And normally the portal venous flow should be much more phasic, just confirming that this is gallbladder wall edema in patient with congestive heart failure. Another pitfall that I think is very dangerous is missing gallbladder wall cancer. And gallbladder cancer is, I think, more difficult to diagnose than we think about it. So in this case, we didn't miss it. This was a 25-year-old woman, and this cancer can present with right upper quadrant pain. So this patient will show up in your emergency department. So she was 25 years old. And I remember one of my colleagues called me and said, well, what do you think about this gallbladder? It looks like there's a mass in the gallbladder. I can barely see the gallbladder. The patient's only 25. Well, we did a CT scan, and long and behold, she has an enhancing mass in the gallbladder, and she had gallbladder cancer, unfortunately, at age 25. In this particular case, the gallbladder cancer was missed. So this was an 82-year-old man with abdominal pain, and the ultrasound was read as acute cholecystitis because there's gallbladder wall thickening, there are shadowing stones, and this area was probably overlooked. Now, one clue perhaps in retrospect we should have thought about is there was ascites. So anytime there is ascites, always look carefully, unless the patient has obvious cirrhosis, because could be a potential sign of malignancy. And there was no video clips obtained at the time either. And this patient had surgery, unfortunately had gallbladder cancer. Now, this particular case, we were a little bit more careful. The sonographer said, well, there is sludge. And I'm like, sludge should not be at the fundus. It should be dependent. And so to look at the fundus better, there is a trick, and there is a good article that's going to come out in Radiographics about that. How can you use a linear transducer to better look at among other things, the gallbladder fundus? So we switched to a linear transducer. This confirmed that this is indeed a mass, and there was even a focal bulge at the fundus. So this was another example of gallbladder cancer presenting with right upper quadrant pain. Another pitfall is xanthogranulomatous cholecystitis. So there is really, I think, very difficult to make the diagnosis, prospectively, because these patients will come with a stone oftentimes, and then they have this gallbladder mass, basically, or marked thickening. For all the world, it looks like gallbladder cancer. This patient had recurrent right upper quadrant pain, and she was lucky. She had xanthogranulomatous cholecystitis. We thought she had gallbladder cancer, but which is a rare form of chronic cholecystitis with a destructive kind of smoldering inflammatory process with, you have extravasation of bile, and you have these lipid-laden macrophages that we see in the gallbladder. In the kidney, it's a little bit more common, I think. You can have a focal or diffuse form, and for all the world, it mimics gallbladder cancer on imaging. Okay, so now we'll talk about the biliary tree. And let me start with this patient. So this was a 51-year-old woman who presented with right upper quadrant pain, fever, chills, and a dark urine. So she had the ultrasound first, and you can see that there is intrahepatic biliary tree dilatation, a very dilated common bile duct, and this kind of soft tissue mass not really shadowing. If you look at the still images, there's also kind of perhaps you can see that there is maybe a biliary thickening of the bile duct. But anyway, if you have a patient with right upper quadrant pain, jaundice, and fever, this is an emergency. By definition, a Charcot's triad, you have to think about the possibility of ascending cholangitis. So this patient's emergency, right? Because they become septic very quickly. So pick up the phone, call the GI doctor, and this patient will have emergency ERCP as well as intravenous antibiotics. So what happened in these entities, there is biliary obstruction leading to stasis and bacterial overgrowth. Typically, it's enteric gram-negative bacteria. And again, ultrasound, if you're not sure, if you can have an MRCP emergency, that's great. If not, CT with IV and water in the duodenum, because that makes it easier to find the stones if you can. And again, emergency treatment. So people always ask, what is a dilated bile duct? So people used to say 3 to 4 millimeters. I think up to 8 millimeters in certain cases, probably okay. Does it really increase with age? Maybe not. It's unclear. Does it get bigger after cholecystectomy? Perhaps. It's really not that clear. I think what is really important is the measurement have to be interpreted in the clinical context. So if I see a bile duct that's borderline, I will look at the LFTs. If the alkaline phosphatase and bilirubin is normal, then it's very unlikely this patient had extra hepatic biliary obstruction. So I think putting things in context with the liver function test is really important. So this is a patient with sickle cell. So he has small gallstones. And his common bile duct is 6 millimeters. It doesn't look that impressive. However, he had elevated liver function test. So in this case, I think it's really, really important to try to follow the duct and see if you see an obstructing lesion. So the best way, in my opinion, to start with is go transverse, a transverse slightly oblique in the right upper quadrant, find where the duct is dilated, and then angle down or press down until the head of the pancreas until you see the obstructing lesions. That's really the best bet. And once you find it, you can turn sagittal and confirm that this is a stone within the common bile duct. And in this patient, basically, we made a diagnosis, so he could immediately go to ERCP for treatment, didn't need an MR. So we saved a little bit of time and money. And I think it's important to teach all the sonographers that if you see biliary obstruction, okay, this is a beautiful case of biliary obstruction. There is intrahepatic biliary tree dilatation. The common duct is markedly dilated. Even the cystic duct is dilated. Don't give me just images, right? Try to find out, because we are there to problem solve. So try to find out why this patient has this much biliary tree dilatation. So this was a case that came several years ago to Johns Hopkins Emergency Department, and we have, very good, well-trained sonographers, and she looked in the head of the pancreas, and lo and behold, there is a big mass in the head of the pancreas in a patient who walked in the emergency department. That's not that rare. The pancreatic duct was also dilated. So, of course, then you go to CT, and here's the pancreatic mass, which, turned out to be an adenocarcinoma of the pancreas. Now, there are times if you suspect a primary liver lesion, liver problem with a patient with fever, probably I would say CT is the first thing to do, but sometimes they'll order an ultrasound. So this was an IV drug user who had this right upper quadrant pain, chest pain, and fever. And this is just a classic appearance of a liver abscess. Nothing fancy about it. Thick wall, debris. Now, theoretically, in a different area, it could be a metastatic disease from squamous cell cancer. They also tend to be cystic. But this was drained percutaneously, and it was an MRSA abscess. Now, so they're not that uncommon, actually, and some of these patients don't necessarily present acutely. Usually, they're pyogenic gram-negative bacteria. They can be biliary in origin, secondary to cholangitis, or they can spread from a GI source, from diverticulitis, Crohn's disease, or perforated appendicitis, and oftentimes we don't really see the source. And then there are the non-pyogenic abscess like amoebic and echinococcal infection. So if a patient has liver transplant, I'm extra careful. And there are a lot of people walking around with liver transplant now. So even if you're not in an academic institution, you may encounter them. So this was a 26-year-old woman who had liver transplant 6 months prior. She presented with right upper quadrant pain and fever, and sure enough, she has abscess. But all these patients, we always look at the hepatic vessels at our protocol. And when we looked at the hepatic artery in the region of the porta hepatis, we normally see it. Yes, there is flow in the hepatic artery, but look at the pattern, right? Dr. Pellerito the other day showed you cases. So this is a parvus tardus waveform. There is too much diastolic flow, and the systolic upstroke is not good enough. So now I'm trying to put two and two together. The patient has liver abscess. Hepatic artery may not be as good as I think. And so I'm going to try to follow the hepatic artery all the way to its origin, if I can. And in this particular case, we were able to, and we showed that there was occlusion of the hepatic artery near its origin. And here's the angiogram proving that that we were correct. And the reason you see flow at the porta hepatis is that there is collateralization of the hepatic artery with several little collaterals forming. They can form, within 2 weeks after liver transplantation. Now, if I not able to follow the hepatic artery, I'm going to recommend a CTA. And why are these patients at risk? Because while the liver is mostly supplied by the portal vein, the hepatic artery is the main supplier of the bile duct. And if the hepatic arterial supply is not good enough, you can have biliary ischemia with ischemic strictures, abscesses, and bilomas. Now, this is just a classic example of an echinococcal cyst, multiple daughter cysts on ultrasound and CT. And this patient was from Saudi Arabia. And, there's an endemic area for echinococcal cysts. Now, what about this patient? So this is a 28-year-old man with sudden onset of right upper quadrant pain. And I wasn't sure what was going on. This is the liver. What's going on? Is a clot. It really wasn't sure. And this patient, if had been interrogated, probably should have gone to a CT first. So we recommend a CT. And what happens? It's very clear on CT, where it's very unclear on ultrasound. There is a big mass with hemorrhage around it, right? So basically, he ruptured, and even a subcapsular hematoma here. So it's a mass that ruptured. Now, he had a history of anabolic steroid use, and basically, it was a man that was ruptured hepatic adenoma. Of course, we think about it in women on oral contraceptive, but again, history is key here. And so when we think about painful hepatic tumors, what happens there is distension of the liver capsule. Usually it's after they rupture or hemorrhage. We always think about hepatic adenomas, but hepatocellular carcinoma can also rupture with obviously disastrous consequence for the patient. Hemangiomas, it's much less common. I think those two are the most common. Now, there are other things that live in the right upper quadrant, the right kidney. And so, if this patient has hydronephrosis, again, if the sonographer just says, okay, there is white hydronephrosis, if the patient is pain, I'm saying, no, this is not good enough. We need to try to find out why. So think about it. Where do calculi in the ureter get stuck? Well, the most common is in the distal ureter near the UVJ. And if the bladder is distended, you can see it. So here's the distal right ureter with a stone. And there is a little twinkle artifact behind the stone, and this patient happened to have a little bit of a ureteral jet, so he doesn't have complete obstruction, but always look for that. Now, this is an entity that Dr. Fishman showed a case of earlier. So this is also a patient who is presented with right upper quadrant pain and foul-smelling urine. So the easiest thing to do is to see that there is a complex fluid collection between the kidney and the liver, probably also extending into the liver right here. And when we look at the kidney, first of all, there are markedly dilated calyces with a lot of debris. And maybe there is a stone here. There is something shadowing. Now, it's not the best shadowing in the world, and there is no hydronephrosis around the central area. And that's the classic appearance for xanthogranulomatous pyelonephritis, because like you saw much better on the CT, usually there's scarring around that stone that's centrally located. And so this is a good example of xanthogranulomatous pyelonephritis on ultrasound, very dilated collecting system with debris, and then look very carefully for the central stone. And here's this patient's CT scan, again, showing the same thing and showing the liver abscess as well. So, we saw this morning that it can spread from the kidney out. So we talked about it, so I'm not going to repeat what Dr. Fishman said. And so if you're dealing with renal infection, now if you suspect pyelonephritis, either it's a simple case and you don't need any imaging, or you go to CT. But sometimes they order ultrasound, and we need to be able to try to recognize these findings. So the ultrasound is going to be often normal in mild cases, but if you sometimes you'll see echogenic areas in the cortex and decreased perfusion, that's what you look for, because oftentimes the severe cases of pyelonephritis have some hemorrhage within them. So this is such an example here. You have kind of wedge-shaped echogenic areas at the upper pole as well as the lower pole, and maybe perhaps you see already a hypoechoic area. This may be like lobar nephronia, what we used to call lobar nephronia, and there is decreased perfusion in that area. So that's what you would see. And this patient had E. coli infection causing pyelonephritis. Now, this is the case in the left. I didn't have a right upper quadrant case, but I want to see completion, show you what this entity looks like on ultrasound. And this was a sonographer that made the diagnosis. He went to the ICU because the patient had urinary tract infection. No, I mean, the patient had renal insufficiency. And here's the right kidney. Looks fine. And here's the area of the left kidney. There's a lot of dirty shadowing coming from that kidney. And this sonographer was very well trained, and he called us and said, you better come up here. I think there is gas within the kidney. And this is what emphysematous pyelonephritis looks like on ultrasound. If you suspect a diagnosis, get a CT. But sometimes, they order an ultrasound first, and we need to be able to make a diagnosis. Is this echogenic area with dirty acoustic shadowing from air? No, air in organs is bad. And so then, of course, we send the patient immediately to CT, classic appearance of emphysematous pyelonephritis, and here the nephrectomy specimen. So again, Dr. Fishman talked about this, so I can skip on this slide. Again, usually diabetic or immunocompromised patient. And this is a rapidly progressive parenchymal destruction. This patient needs emergency nephrectomy. So here's my take-home point. Perhaps the most important thing is that acute cholecystitis is not as easy to diagnose on ultrasound as I initially thought. And we really have to think, especially if you have a high-risk population, to think about gangrenous cholecystitis. Always think about it because, if you make a correct diagnosis, obviously it's much better for the patient. In a symptomatic patient with biliary tract dilation, insist that your sonographer look for the obstructing lesion if they can. And again, know the limits of ultrasound. I love ultrasound, but I know that its limitation. And in these 6 patients, you want to understand when it's really important to recommend additional findings. And with that, I thank you for your attention. Have a great holiday, safe flight back. And Dr. Fishman, thank you for inviting me. And then